over at ProHealth is that they try to use all of their workers, employees, in different areas, so we get trained in different areas, so that when a new study comes along, rather than hiring someone from outside that's new, they try to shift us around like chess pieces because, oh, so-and-so, this is their skill, they can do this is that, and they switch people around, which is very nice because we get experience doing different things. Mm-hmm. So, since I've been there, I started out as a interventionist in a weight loss study. That's what I was hired for. Okay. After that, I went to a pilot study, which was weight loss for postpartum women. Wow. And then I started working with Gayles. Everybody know her?
She's actually on the specialist group for behavioral health.
Behavioral health. Yeah. She works with her main focus
is smoking cessation.
Well, she does smoke cessation, but her main focus is severe mental illness. Okay. And then she goes down to smoking cessation, weight loss, those types of things. So I worked with her for several years. Pilot, another study that she had, a peer study over here at Hopkins at the hospital with exercise and that type of thing. So I worked as an interventionist for weight loss on that one. And also learned how to do the exercise, but we had an exercise person, but we worked in teams of two. So able to do that. That one I say was the most rewarding job that I had because I didn't know much about mental illness. I had seen some of it in my family, and most of us on the team did not know. We were brought together with some very phenomenal consultants, psychologists, psychiatrists, different people like that, that helped us out because all we knew is what we did, but we didn't know how to navigate in that world. So we learned a whole lot. And to know that there are people with mental illness who are being treated for their mental illness, so people are not really paying attention to their physical illnesses. And we found out they'll drop dead like 15 years before the general public. Just cardiovascular disease just takes them away while they're working on that. And so we were able to do something, and we just felt good because we found blockages, because anyone who had diabetes had to do stress tests and that kind of thing, and we were able to detect some blockages in people that would not have gone to a cardiologist because there was no reason, as far as they knew, to go to a cardiologist. And they actually said, you guys saved my life because I would not have gone. And he was going to be one of those that probably dropped dead. And we would say, well, what happened to him? So it was very rewarding to work on that study, to know that you're helping them here and helping them to move, because that's all part of the cardiovascular. And just helping them to move whether they lost weight or not. They were just being more active. So I worked intervention, so that was weight loss. Then I also came back as an interventionist. And then I got the opportunity to work with Dr. Boulware's study as a community health worker. I'd never worked as a community health worker before. And I went back to ProHealth. This is how things happen at our place. I went back there after I left. I was a coordinator. I forgot that. I was a coordinator of a study called 5+ Nuts and Beans. And
if I can just interrupt. Yeah. So 5+ Nuts and Beans. So were you with the ACT study?
I was with 5+ Nuts and Beans first.
Okay, so
at East Baltimore Medical Center.
Right. So when Dr. Cruz came here and when Dr. Miller came here, they both talked about their work that they're doing, and that 5+ Nuts study is the predecessor to a study that they recently just got funded. So as we talked about yesterday, when we were talking about how Rich Life is kind of a blend of two different studies that came out of the center, the ACT study, which used community health workers, did they?
ACT study used community health because that's where I got my experience.
Right, and then the other study was, I forgot its name, but it was a systems level study that Dr. Cooper and Dr. Marsteller, who are the co-PIs of Rich Life, they were also the co-PIs of that study. Mm-hmm. So they basically blended the two studies to create Rich Life. So I just wanted to provide some context when she talked about 5+ nuts.
Yes, that's when 5+ nuts and beans started. I was the coordinator for that. I was coordinating for that. So you do get experience. I was coordinator, I did the recruitment, I did everything. I was blinded to the outcomes, so I did not do the data collection, but I had to prep all the documents for that, and we had 2 other people that actually did the blood pressures and weights for the data collection, so I did all of that. And I'm proud to say, and I hate to do my own horn, however, it's very important from where I come from, we had 100% retention. Every single person. And, we are trained that way. I don't know if you all have met Jean Charleston. I know some of you have because she teaches the blood pressure. That's her main thing is blood pressure and taking it the correct way and that type of thing. So she's the expert in that. And she also is the expert in recruitment and retention. So she drills it into us, things that we can do if you're, come up with a situation or something like that, and then you start to, your brain starts to click, what would Jean do? What would Jean do? And so I got my 100% not so happy. And so I went back to Pro Health because I knew they were going to put me somewhere. And that's I helped recruit some other studies that they were doing. And then a call came from the ACT study. They were looking for a community health worker. And Jean encouraged me, that's another thing, we have encouragement as well from our administrators. She encouraged me to come back to the health center, East Baltimore Medical Center. She says, why should they hire from outside, train someone when you know the system? You haven't been a community health worker, but you have the skills to be a community health worker. So I would recommend that you go back there. I'm like, I just got home. But I went, and I'm glad I did, because that just added something else to my resume, and it's not just my resume, but just to my personal life. It added something. And so I'm so glad that I did, and I'm glad that Chidima and Katie asked me to come and speak. I'm not a speaker, but I'm one that likes to relate a story and experience, and anything that I think would help you all out.
Sounds great. It sounds like you were always in the right place at the right time. It sounds like that you're just, I don't want to say lucky, I want to say blessed to be able to have your job here at Hopkins where you are, because not everybody, I feel like, would have that opportunity to be able to sort of go from like multiple studies within one healthcare organization. So you must be really phenomenal at what you do, because it seems like they recommend you.
Thank you
and
so
they
much.
pull you a lot to do these
I
things.
am
So
so
that's
thankful
great.
for the opportunity to be at Hopkins.
Especially for it to last
And
for
for the
so
last, right.
long for you.
And so many different experiences. And now I am kind of transitioning. I will have a part, at least it's working out that way, in the new 5+ nuts and beans and kidney, because I have experience in the first one. And so I'm learning about that.
Yes.
When did that,
I'll tell you where that came from. Actually, I didn't know. The study of 5+ nuts and beans was looking at the theory that if you eat a combination of 5 fruits and vegetables plus a nut or a bean every day, you'll get the approximate amount of potassium that you need that will benefit your health, as far as, especially if you have high blood pressure. So we were working with African Americans that had high blood pressure, but not the ones way out of control, but the medium one, that may need some help or something like that. If they eat the 5, got a certain 15, I forgot, 1,500 milligrams of potassium in a week, it would help with their blood pressure. So that's why we call it 5+ nuts and beans. And so now they want to relate it, you're welcome, to the kidney disease, which I have to read some more about it and look at the protocol. but it appears that I may be working as an interventionist on that study. So I've had like many roles. And it was suggested by my manager that I take a look at it and take it because of my experience. So we have people that are looking out for us, and you know, and it's good for all the projects that we work on. And I didn't say I'm a recruiter right now for a study called Sturdy, which is a vitamin D study for people who are 70 and older. The theory is that our focus is, because there's a lot of vitamin D studies, that vitamin D will help to either prevent falls, lessen the injuries, severity of injuries, and help with balance in people 70 and older. And if it does help with that, how much vitamin D do you need to take? So people are being placed on 4 different levels of vitamin D. It's a double-blind study, so they don't know how much they're taking, and we don't know how much. But the people who are monitoring do. And this is the first study I've been on where people could start off on one level, but end up on another level, depending on what their vitamin D levels are. So the ones that are monitoring will recommend that.
Actually, so
Got it.
only because, well, first I think
Sorry.
it would be, no, don't apologize, but I think it would be good if we all introduced ourselves so that you have a sense of who's in the room. And then, you know, we're talking about home safety, and like when you conduct a home visit. So there are care managers here and community health workers.
Oh, okay.
Some of you do home visits, right?
Yes.
I was going
Right.
to ask that.
So I know the CHWs do, but I mean the care managers. Some do, some don't. Okay, so yeah, so there's a mix of experiences
Oh, sure,
here.
sure.
So I'm
Here.
Chidama, you already know who I am.
Chidama.
I'm Danielle, I'm a community, I'm a case nurse. It's been a long week, okay, and I ain't had my coffee all the way. All right, let me start this thing over, okay? I'm a nurse care manager with Total Health Care.
Oh, okay, awesome.
Hi, I'm Dorethia. I'm a clinical manager at Total Health Care, but I'm also here because I will be supervising the Rich Life project at Total. So I felt like I needed to take the training in order to supervise, so I know what's going on, what's needed, or whatever else might have to possibly play a part.
Hi, my name is Helen Owanda. I'm a community health worker at Total Health Care at the division site.
Good morning, my name is Vanessa Adams. I'm a community health worker at Total Health Care at Saratoga, True, and that site.
I'm Gloria Leonard Witten. I'm a case manager with Johns Hopkins Health.
I'm Teresa Messer. I'm a case manager with Johns Hopkins Healthcare in Hagerstown, and I do just periodic home visits because of our small community. I'm able to do some.
Hi, I'm Cheryl Sprague, nurse case manager at Johns Hopkins Healthcare at Belcamp, Versailles, in Harford County.
Oh, okay.
I'll get there.
Where are you in Harford County?
Hello, I'm Raven Randolph. I'm with Johns Hopkins Healthcare. I'm a community health worker for the Anne Arundel County area.
Hi, I'm Lauren. I'm a community health worker at Johns Hopkins Healthcare. I'm at White Marsh, Green Spring, and Belcamp.
Hi, I'm Mary. I'm a community health worker at Johns Hopkins Healthcare. I was hired for Regions 4 and 5, which is Montgomery and PG County, but I've been doing other communities.
Interesting, from all around.
Yeah.
That's awesome. Thank you for inviting me. So who does community health work now, like home visits? Oh, okay. So some of this you probably already know, and you can add to it. So I'll just go on, like I said, I'm not a speaker, but I can relate experiences and just some of the general rules, because it might not be the most interesting thing, safety, but it's one of the most important things. In fact, it is so important, not only safety for the community health worker or whoever the team is, but it also for the participant or the patient. Safety is so important. And so, as I said, I got my experience as a community health worker working with the ACT study. And I don't know how you all felt when you first got it. Most of you Why did you get into community health work? Just brief. Why? Why are you doing?
My mom opened a nonprofit that was basically community health worker work. So when I found a position that was similar, that made me apply.
I had worked in administration, and I wanted to give back to the community, and so when the community health worker program initiated, I applied.
I started out as a case manager for a home care organization, and from there I just started doing home visits, and then I found out I liked it, and so my next job I was an outreach worker.
So I just love working with people. I love the health field. I love the information. I love the just being able to encounter the difference between people personalities, personalities and connection. So it works for me. I think if nurse know nothing that exists, community health work, I still will help people anyway. So it's like free.
Anyone else?
I started out as a health educator, and I felt like a community health worker has more of a direct impact, which you can see.
Okay, well, as you heard, most people got into this because they like it. That's what I heard. They like what they were doing. You have to like, I'm sorry.
Oh, no, I didn't interrupt. I just wanted to ask the care managers the same question.
Oh, okay, sure.
Why we became care managers? Somebody else start, I have to.
Well,
I came to Hopkins actually like 13 or 14 years ago after being a home health care nurse and a home health care company coordinator. And so I really liked home visits. And then when I went to Hopkins initially, I was one of the office nurses. And when the case management position came open, that they were going to start a case management program with an embedded case manager, I thought would be a good opportunity to be able to do something a little more specific with patients and work more closely with them.
Well, I came to Johns Hopkins in 2012 after covering several areas of nursing, and I was hired as a coding nurse, transitional care, triage nurse all in one. And transitional care is what gave me the interest towards case management, because we did the hospital discharge and the follow-up and things that need to be in place. And I was like, I like this. I like this. In fact, my practice administrator was like, you gotta let it go and give it to a case manager. You've done your little thing for maybe 2 days, let it go. I was like, okay, I like this. So I went back to school, to put things in line, and then I applied for a case manager position. So I've been in this position for a year and a half.
For me, I am passionate about community. I'm specifically passionate about the African American community, health equity, ensuring that folks in my community where I come from, people that look like me, maybe have had some shared experiences like me, get quality care. And so one way I can do that is sort of by being a community health nurse. And what that means to me is that I can sort of advocate for patients on a community level. And when you affect folks from the community, you affect families, you affect populations. And that's why I got into care coordination, because it helps me to have some autonomy as a sense, as a nurse. Because most of these types of positions are grant positions, so folks sort of write the grant, but some administration may not really know how to implement it. And so I was really good at implementing a care coordination program from paper and then putting it into practice. And I understand the importance of it too. I understand that the goal of it is to reduce admissions to hospital rates. And that's why I like care coordination. Yeah.
Did you answer?
Oh. I was trying to think, because there's so many different reasons, that's why I was hesitating.
I had been in hospital all my career, so different areas, but all in hospital, and so I wanted to try out of hospital. And so I really didn't know what I was getting into, so it was something to start in, to try and see, okay, here's one aspect about a hospital, see what it's like. And then once I did it, I decided, yeah, I really like it because, one, the autonomy where you help the patient problem solve one-on-one, that is so unique as far as a nurse career that you can do. And also the thing is also personally, I see so many non-medical, my parents, different people, they have no clue how to navigate the health system. And watching that and seeing what a difference you can make for these people that I equate sometimes, boy, this could be my mom and dad. And you make such a difference, even little things. And so that's why it's kind of multifaceted. Thank you.
Oh, you said why?
Yeah. Well,
And
I can
Supervisor,
share
go why
about I'm just like, I forgot the name. Cheryl. I've been in the hospital for most of my life. Coming to Total Health Care has been my first encounter with healthcare outside of the hospital. There's some aspect of the hospital that I miss, but I really like this side because I can problem solve with the patients because I am the clinical manager, and anything that goes wrong, the patients will come to me. So I'm able to help them problem solve. I'm able to help them sometimes get with what it is that they need, and sometimes I can't. Sometimes I have to actually side with the provider, you know, but before I do any of that, somebody has to tell me what's going on, why the patient wants to see me, because I don't want to sit in front of them looking like, so, because you know a patient is going to tell you their side of the story, but then the staff is going to tell you exactly what happened. So I need that piece before I get to the patient. That way I can have a response for the patient, but if I feel as though, okay, this is something that is really needed, I can work with the provider. You have to negotiate and soothe over the provider to get what's needed, but I really like this side because I'm learning so much. I even had to stick a baby. I didn't like that part. I'm learning so much with this, and being a part of this project here, I have learned so much. It's not that I learned so much because a lot of it I already knew because we learned in nursing school, but it refreshes what you learn. How you going to use what you learn, how you going to word it. For example, motivational interviewing. The way it's scripted, I know that we, with our population, we can't put it that way. We have to tweak it for the patients. So it's been a lot. I really like it. And this is the part where I want to stay. The hospital, I loved it. But I like this part better.
And one thing, I didn't say how I got into this business. I was like Lauren. I was in health education. I started out as a dietitian in the hospital, and then they moved me into health education, breast care, prostate screenings, diabetes support, smoking cessation. And then one day I thought, you know, I loved it because I was helping people in these groups and that kind of thing, and I happened to see an article from Hopkins while I was out on surgery, and I said, this has my name on it. And I said, this is research. I've never worked in research before. And I said, well, as much as I love health education, and I help a person here, in research, you not only help people one-on-one, in groups, but then the whole thing gets written up in journals, and then you help mankind. I mean, it's grandiose, but you help mankind, but you do. I mean, we've seen the articles that go out from the studies that we work on, and our work is important. So what you all do is so important. People, your everyday people and your relatives might think, oh, they do that, but they don't know. And when you start to think about it, you're like, oh my gosh, you know, you work with Larry Apple, and he's the one to help to design this, and blah, da, 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 da. So that's a big deal, even though it's in our world, but it does help other people. So that's how I got into research and out of health education, because I can do a little bit of both and see the results. So, back to home safety. Some of you have had the experience, home safety and how important it is. And with the ACT study, we had some rules. And what I did was pull like some of our paperwork. I'm sorry I don't have any handouts, but if you want to make some copies of these, you can. You know, it's very basic and simple, and some of you already have had this experience. But our one rule is that we had was visit in pairs. And we had a team. We had a coordinator and the community health worker that went to visit the home. Now in our study, we were in the person's home for 2 hours. So we were there a long time. The coordinator had her part when she did a survey that took about an hour, plus she also did an assessment of the person's cabinets. She had to look in the refrigerator, see what foods they had, and that kind of, it was very invasive as far as, you know, participants' home. So she had an hour. And then the community health worker, my position was to bring them their blood pressure machine. Everyone got a blood pressure machine. And so there was the education, you know, what is high blood pressure? What do you think it is? You know, whatever, and they tell them what it is. They got a little pamphlet. What can you do about your blood pressure? Because there's some things you don't have control over, but there's some things you do have control over. So the education went on about that. We gave them that. Then we educated them on their blood pressure machine. How does it work? This is an example. We do this. We put batteries in, you know, all of that. Pulled it out of the box. It was brand new to show them, you know, and we let them know where's the best place to be when you're taking your blood pressure. What is the condition you should be in? Go to the bathroom, you know, have light, comfortable, arm on the table, you know, so that you're not working, extra work and that kind of thing. So we did that education, and it took an hour. All of that was recorded. We had an audio tape, and we recorded our education. And it got downloaded on the site. So we always went as a pair, and I'll go into some of that later. Notify the appointed person. Now, I don't know how this study is set up, but the appointed person was back at the study. It was either another coordinator or it was Patty Ephraim who worked on our study. We'd notify when we arrived at our destination, because you have to think of safety, you just do. And after a while it comes, you know, natural. You notify when you arrive at your destination. You notify if you think the visit's going to go over the 2 hours, let someone know. Also, let someone know when you leave the appointment. These were general rules. And wear your Johns Hopkins badge at all times. Now, some people, you know, from where I come from, we all have to wear what we call a uniform. Everybody has a lab coat, and we have to wear it. Doesn't matter which you can't wear, you know, a bathing suit, but as long as you wear your lab coat, you're in uniform. So I was the only one wearing the lab coat, because the other ladies didn't, but we all had our Johns Hopkins badges. So those were the 5 rules that were important that we had to follow. And some of the other things I could add on, but they're coming up. Personal safety, okay? Limit your valuables. You all may do this. Money that you take, credit cards that you take. Don't let your wallet be in view. Keep it away. Yes.
Well, I just, as a rule of thumb, before I even go out, I just put my purse in the trunk, so I don't take anything in anyone's home that would make me vulnerable.
Mm-hmm.
So I've always done that.
That's a good idea. That's one of the things.
And it's not even just going into the home, it's walking from the car to the home.
Yeah.
To the home.
Out of the home, back to your car.
Exactly. Mm-hmm. Exactly. And so secure your personal items in the trunk of your vehicle. And I always say, I mean, I do it at home, even if I'm going to the mall or something, and I know that there's something I'm going to put in my trunk, or from one mall to another. I put it in the trunk at the one place, and then go to the other place.
Right.
I don't go to the other place and then put it in the trunk.
Right, because
No.
people watch it.
People watch
Yeah.
it.
Yeah, that's fine.
So, you secure anything that you're going to do before you get to the home. And then maintain your professional, oh, yes, ma'am.
You know what I also do when I go to the home? I take a folder, but it's plastic, because sometimes people will have like bed bugs. Bed bugs or like other things that you just don't want to take back with you to the office or home. So I take as limited, very limited, just what I need to go in there, and it's in the plastic folder, and that's what I take in now, because you don't want to bring company back with you.
That's right. You think of ways of making yourself a little more safe, and yeah, that's one. So that kind of thing. Well, you know, grooming, image, you know, that kind of thing, and not a lot of jewelry. You know, you want to show off all of that stuff when you go. Well, you have to say it. As Johns Hopkins employees, we are not allowed to take concealed weapons, which somebody might think of, you know, you don't know. So we cannot.
You cannot take guns with you, you mean?
No, can't take guns. or knife. Or knife.
Can't take the taser, that's
No
bad.
taser.
Pepper spray.
Don't spray. Nobody concealed weapons.
Actually, no joking, I don't even know where I read, but don't they advise community health workers to carry pepper spray or something with them? Is that considered a concealed weapon?
I think pepper spray is illegal in Baltimore City.
Oh, it is?
Yeah.
Okay.
Yeah. Isn't that crazy?
It's illegal.
Yeah, you
That's
can't
crazy.
carry it.
People used to carry it all the time.
People still carry it, but you're not
Still
supposed
carry it,
to.
but, I mean, you used to, everybody had a
Yeah.
pepper spray hooked on their key ring.
Yeah.
Still do.
Whatever the spray
Yeah.
is.
Well, I don't know.
If somebody's accosting you,
I
you're
don't
in
know.
trouble.
And as far as your relationship with your, do you call it patients or participants? Because we say participants. Patients. And you probably already found this. When you're talking with them, you don't divulge any personal information, work-related or non-study issues. You don't want to get into that. Oh, I've got Mary Kay business. You know, by the way, you want to take my card? You know, you don't get into that with them. Anything like that. You know, you keep it. You know, about the visit. You can be friendly, but not over-friendly. My best bud. And one thing that I have to say, because Valerie works with us now over at Pro Health as a phlebotomist, and she's doing visits, screening visits with our people from the Sturdy study. But Valerie, you know, we got to know the people so well. They almost seemed like they were your buddies, like your friends, you know, like somebody you could socialize with, or just somebody you were just close to. They seemed like your mom, or, you know, your auntie, or something like that. But you had to remember, they're not. You can treat them, I would say, you treat them with regard. They're important. You let them know how important they are and how important they are to themselves as far as taking care of their health. But you can't be buddy-buddy and don't invite them over, that kind of thing. And some of them felt the same way because you were kind to them, because you cared about them. I mean, you all know you care about the people that you're working with. You do, you know.
I was just curious, what are some of the phrases you use to stop it when they say, oh, why don't you, whatever, stay and have lunch with me, or why don't we this, when they want to make it more of that, what are some, I'm just curious.
Because there are times when they know you're coming and you have people that have the gift of hospitality, and so they fix you lunch, or, you know, they have things for you, and you're like, oh my gosh, I am so sorry, I can't accept your lunch. I just had lunch. You know, oh, this is so nice of you. You know, so you play that part up. I have no bread. You know, you just play that part up, and it's hard because there's some people who want to give, and they think, you know, they're doing that for you. I think at the most we've taken a bottle of water from someone, but we even try to bring our own water. Not take anything from them, but at the most I remember taking a bottle of water. We've taken water from them, but you know, no fruit milk. Oh, we did take an apple one time. You know, there's times, and you have to play it by ear, what it is, and who the person is, and that kind of thing. But you make a rule not to take anything from them, and try to, you know, express your thanks and your appreciation for what they're doing, you know, that kind of thing. You know. Sorry. I mean, you know, you've had to say that to relatives. Had family in New Orleans, and you go to visit one, and they've got this whole spread of food and whatever, and then you go visit the other one, they got another spread. Food that they think you can eat. You know, so so you'll think of it as you go along, but there are some that are very hospitable and want to fix you things and want to give you things.
Who want to be your friend,
and
they want to take it a little.
Yeah, but one lady wanted to be my friend on Facebook.
So how did you handle that?
She just gave me her, you know, well, I knew her name, and she says, I'm on Facebook, you looked me up, and I'm like, but I never looked her up, you know, friend me, you know. I just didn't do it, and, you know, she didn't try.
I think it's hard because we have our badges and our names on our badges and we get
Yeah.
our business cards, and then all of a
Yes.
sudden you see somebody on Facebook and there's a friend
request.
and it's kind of like, oh, no.
And you can't. And sometimes you just have to say to them,
Yeah.
you know, because of my job, I just cannot do it. And there are people that do understand that when you tell them.
And then there's the patient that you run into in the community when you're doing your shopping or whatever, and they want to include. And I always let the patient know if I'm able to talk to them, you know, like, you know, I really don't divulge that I'm your case manager or whatever. You know, that's between us. I kind of let them know that so they're not embarrassed. Because I have been in a situation where it was a high-ranking person, and I was doing home health. He put it in their digest, pictures. And I was there, and I was like, okay, so you've already given permission, you've already done that, but I'm not going to advertise that I was taking care of you. So you have to be really.
You do, and especially now with the social media and everything, it
And
wasn't like that before.
Not only that, it's just the idea of the thought that you could be manipulating that person or in it for financial gains or whatever like that, so you have to keep it professional and separate all the time, no matter how nice, and you have, sometimes you just have to come out and say, you know, I have to keep it this way because this is a business situation, or I don't want anybody to think that I'm taking advantage of you or you're taking advantage of me. We have a goal, we have needs to be made. And, but they put it out there, all in the paper.
And then there's HIPAA.
Right, it was HIPAA.
And then there's HIPAA,
And it was
you know.
HIPAA, and I'm like,
We see participants out, you know, I've seen them out, and now if they tell me, you know, if they say to their friend, I'm in this, but that's them.
Right.
Okay, I'm not saying that, because I'm not going to say it. I may speak to them, hi, how are you doing, you know, whatever. But if they say it, that's on them. I'm not saying that, because then I'm in violation of HIPAA. They're saying it. But it's their business, and they can talk about what they want to their friends. That's the way I look. But I would never divulge that information to anyone that, oh, this is a lady with my stuff. No. So there's a lot of things, and there's fine lines, a lot of fine lines. And if you have someone that you can discuss that with, like you have a managers group, and you have a nurses group, or, you know, community health workers group, that you can talk to about that this situation came up. I had a lady came in our office, and she was having a visit, going for a doctor's visit, and they would always stop by our office first, and we would download their information off their blood pressure machine for them to take to their doctors. And so she was there, and you know how you, this taught me a lesson. Oh, that's a beautiful person. She says, oh, you can have this person. She said, my daughter gave me this person, this is not my style, blah, blah, blah. And I said, oh, no, I can't take the gifts you just, she said, all her stuff out. She had a plastic bag. She says, well, take it or not. It's yours. It's on the desk. I'm not taking it with me. And she refused to take it with her. And I talked to my manager. She says, well, Deb. I said, the coordinator was there. She saw it. We documented it. And I said, that's the last time I'm complimenting anybody on their purse or anything like that they may leave with me.
Now,
She collected everything out of their
She
purse.
must have had a problem with her daughter because I don't know any woman that'd give away a good bag.
And it's a Michi bag. One of those Michi bags you can buy the magnetic thing. It was nice with the print on it, you know.
She must really didn't like that bag.
She said, this is not my one. But if it was my daughter, I would keep it myself anyway, even and wear it just because my daughter gave it to me. But this lady, she was adamant. She dumped stuff out of that bag so fast. I'm sitting there with my husband.
If it wasn't the type of bag she would carry, why is she carrying it?
Yeah. And she's gonna walk out with a bag like this out of the hospital.
Wow.
Out of the clinic, with a plastic bag. But anyway, so things happen to you sometimes that you don't have control, and sometimes they do catch you off guard when something like that happens. So, but I definitely gave that information to my manager, let her know. I was not in the room alone, so the coordinator was sitting in the room with me. So she saw it, she witnessed it, but she said, well, Ms. Deb, I don't think it was anything you could do. That lady was leaving that bag anyway. That's why I gotta let Jean know. She's gotta know. So, that kind of thing, but you try to discourage people from giving you things. They wanna give you things, they wanna make you things. It's hard, it's hard. So we talked about that. And if someone says something disparaging, something negative or whatever, don't get in an argument with them. You know, you just say, well, you're entitled to what you believe, whatever. And you don't even have to say, but I don't believe it, because that takes it around another way. Well, that's your belief. And you let it go. But don't get into arguments with people you don't know who they are. I have upstairs. But anyway, or what their strengths might be, but you just don't. And as far as scheduling, now we used to have a form that we would call for reminder calls for the home visit, because it was like one of the first things they did was the home visit. We made the appointment. And on that form, and I couldn't find a copy of that form, but on that form, you would ask them specific things. You know, you let them know, I'm so-and-so, I will be coming with another team member, their name is blah, blah, blah. We will be at your home for about 2 hours. This is what's going to happen. You know, there's a survey. We're going to ask permission to look into your refrigerator and take a survey of what you have in your cabinet, that kind of thing, and ask you some shopping questions. And then you'll get education on your blood pressure machine. We'll bring a brand new blood pressure machine for you, and we will teach you how to use it. And that, so we tell them. Then we ask them, who will be in the home? Do you live with other people? You know, how many people are in the home? Do you have pets? What other kinds of things would you ask them?
I would ask them about parking.
Parking,
If it's
yes.
an apartment or a condo.
That's right.
Is it people hanging outside?
Right, whatever you want to know, and you would ask those types of questions, and you don't feel bad about asking that. You just have to know the whole situation before you come to that home. Then before we went to the home, we would call them before we left. So we not only let our supervisors or someone know that we were leaving, we also called them and said, we're getting ready to get on the road, and we're going to be at your home by such and such a time. We also called them when we reached their home. We didn't just get out of the car and knock on the door. We called them from inside the car and said, we're outside your door, or we're down a block, just to make sure that you're home, and you know, that you come meet us at the door. You don't never go into the home with someone else. You want the person who you have the appointment with. Now, if they're bedridden or something, I don't know if you see those kinds of people, but we didn't.
What kind of people?
Bedridden. To be at the to welcome you in the door, and not a child letting you in the door, kind of thing. So you want the responsible person. Well, you plan your route and all that thing, and, you know, as far as locking your car, make sure your car door is locked before, and then as soon as you get in the car, make sure you lock it, make sure you look under your car. You know, they tell you those things, look in your car, look in your back seat, just make sure. It sounds silly, but it's things that you have to do. Be aware of your surroundings, like are people hanging outside, that kind of thing. And you don't want to cower and look scared, you just want to, with authority, you're walking on, and you're either going to your appointment or whatever. And most people, so that we saw, respected the fact that here were people coming in. And I always had my coat. It might have been a white coat or it might have been a black coat, but we all had badges, and they knew that there was somebody that was germane to this person's either health. Maybe they thought we were medical people, or maybe not, but they knew that it was something that was important for that person. So sometimes people speak, and you just speak back, hello, you go in the house. Just being aware of your surroundings, and carry your keys in your hand. Make sure when you leave, don't be rummaging in your purse. Get your keys together, or if you didn't bring a purse, pull your keys out to get to the car. Get in the car, lock the doors, that kind of thing, to protect yourself. Anybody want to add to that? Schedule. Oh, what about, how do you schedule your appointments? Are they all during the weekday, during daytime hours, 8 to 5, or do you go on weekends, or anything like that?
We all be during the week from 8 to 5.
8 to 5, okay. Just didn't know. That's what we did too. Now, we had a couple of people that we went on a later appointment. And they were kind of different because we were used to doing daytime appointments, and this person, you know, they had a work schedule and they could not, you know, be available, couldn't get off, that kind of thing. And so we went to maybe a later appointment. So if you went at 6 o'clock, you weren't getting out until 8, because it was a 2-hour visit, so it was going to be 8 or after. And I remember that sometimes we couldn't go together because leaving at 8 o'clock, you want to go home and someone lives this way, there's no need in coming back to the East Baltimore Medical Campus and then, you know, leaving. We would just leave from there. We would agree to leave from there. So there were a couple like that, but when we were waiting for the other person to get there, you always wait and you stay in your car and you communicate by phone, you know, if the person was lost or whatever, you're sitting there. And I remember a lady, she was waving from the balcony, you know, but I wasn't going to get out of my car till the nurse got there. We had a nurse that worked with us sometimes too. Well, yeah, that was not like one of the full-time employees with us, but she was from Hopkins. And I was waiting for her to get here, and she got lost or whatever, but I could not get out of my car until she got there and we walked in together. But you just have to do that. As far as protecting yourself. And when you're entering the home, we already talked about some of that, entering the home. You go in, the member who you're associated with invites you in. You always have to remember that they're inviting you into their home. This is their home. And so you treat them, like I said, with regard and with respect. You don't have to be there. You know, they did not have to agree for you to come to their home. So you keep it on that level. And if they have pets, because you've already asked them if they had pets, then you ask them to restrain them. Sometimes, like someone like, oh, I have a cat, he doesn't bother anything. We went to that house, that cat was pouncing. I mean, actually pouncing. I'm like, what is going on? Pouncing from the back of the sofa, here and there, and I'm like, oh my gosh. But it didn't come over to our table and walk on our papers.
Might have had a cup of coffee that morning.
On our paperwork. But as far as any other animals, that was the only one that I had. Now, Valerie had a problem because she has allergies. And sometimes, like that cat would probably trigger her asthma to start or her allergies to start on. So when you have something like that, you may have to plan a visit somewhere else and not in the home. And we did that as well.
You know, I was sitting here thinking when you said the questions you would ask the patient or the participant, I was saying to myself, ask the participant or patient, do they have any allergies? I was more so thinking on that line, because you don't want to go in wearing your Bath and Body Works or your Cartier Gold Must, and you know, and then the patient just, they can't breathe, and here you have one of those adverse reactions going on. I was more so thinking that, but it didn't pop in my mind about.
Yeah, I'm glad you brought it, because it could be on the other side. They may have allergies, so you don't want to be loaded down, because I'm a person who likes to wear perfume. If I'm going to a home, then I would make it like this, or not put on that extra perfume. But that's a good idea to ask the person if they have allergies, because a lot of people do nowadays. They have allergies. So if the person refuses, like they have a pet that's really, you know, you're uncomfortable with that, then you just can't complete the visit.
You gotta put Joey the pit bull up.
You either gotta put him up, you either gotta put him up, or you can't complete the visit, because there were times when we could not complete the visit, and we had to make other arrangements. Also, suspicion of weapons or drugs, anything like that, alcohol use, no. You do not
So how do you
stay
explain
there.
it to the patient while you're leaving?
We did not run into that, but the same thing. You know, I think I'm going to have to go back to the office. Something has come up. And then you leave. We'll make arrangements to complete the visit on another day, and we'll give you a call. So that you get out of here.
That's
We
one of,
had-
I'm sorry, it's one of the nice things about having a work phone with you when you go in.
Yes.
Because you can go, oh, I just got a call, I'm sorry, it says urgent, can we reschedule, I have to go back to the office.
Exactly. And you
So-
have a work phone. Do you all have work phones? Like we all had a work phone, and it's supposed to be on silent anyway, so you can always look at it and say, yeah. Also, we did tell them, and I couldn't find a copy of the consent form, but we also told them if we saw signs of abuse or anything like that, that we would have to report it. That it's the law.
When you say think of signs of abuse, are you also thinking about sort of like how kept or unkept the person is? So like if you walk in and there's trash everywhere, it just looks unsanitary, it's a elderly person that you're going to see, how would you handle a situation like that?
We had some situations where there were homes like that, and so what we did is come back, and we had not only our coordinators, well, our coordinator went, so it was all documented what we saw. And then we talked to Patty, who was the supervisor over us, and then she would decide, you know, what do we do with that person? Is there a family member? Because you have contact people. You not only have that person's contact information, but you have, you know, a relative or someone else that you can contact if you need to. And we sometimes had to contact those people and let them know what we saw. Now, they might have already known, they might have, but you can't just let it go. Especially if you think it's an unsafe situation for the person.
Well, if it's unsafe for you to,
And
if you feel like it's unsafe for you to be in, that's one thing that Adult Protective has always, numerous times said to me, if that's the way the patient prefers to live, that's the way they prefer to live. And unless there's a reason that their health is in jeopardy.
Right. Now, if they say that to you, you document that too. But you know that you
Right.
have reported. Yeah. Because you are comfortable with that.
I think when we're talking, I think about people that are hoarders, because
Yeah.
you don't know if they're bugs, if
Yeah.
they're bugs, mice, or for that patient after you leave, they're a fire hazard.
Yeah.
Do you offer some type of intervention though, like trying, I don't know if there are many like nonprofits in Baltimore that do this, but that would like go into a patient's house and sort of help clean it up and make it a safe, clean environment
It's called
again.
1-800-JUMP.
Quarters very alive.
But you know how they have those crews on Hoarder that will come to the patient's house and they group together and they get all the trash out the patient's house and help to clean it up and make it a safer, functioning place again, because I feel like that's a health risk, right? That's a safety risk for folks, and sometimes it just gets out of hand and people just.
It also, we just had a friend who was over our house yesterday and was talking about his sister who was such a hoarder. But it also, there's some deep psychological things that go along with it, as you've seen with hoarders, and it doesn't like happen overnight. And we were fortunate enough to be in the East Baltimore Medical Center where there were social workers that we could talk of. We had great resources there that we could share with them what we saw and that kind of thing, and that person would let us know if it was something that you could do, something maybe you could not do, that you had to leave it, or, you know, they would give us great advice. So we were really blessed to have those types of resources. And we also thought of other resources for people if it was something that they needed, their gas and electric turned on, or their, you know, whatever, transportation. We helped them with those, if those were barriers to them getting, either being in good health, getting to their appointments and that kind of thing, we helped them out with that. Some needed to get the MTA mobility, and they weren't signed up for it. So we would start the process for them. We went downstairs to somebody who does that and asked her, what do you do? And she gave us paperwork, and we would help them fill it out. So we did work with them as far as resources that were barriers to them taking care of themselves, because they have these things going on. Here with the blood pressure is. I'm like, says, oh, what difference is it gonna make? You know, I've got this. So we had to go through her list that she felt was important to get down to taking care of her blood pressure. You know, you gotta cut those things down. And so that, and like a lot of you said, the working one-on-one, you're able to do that with people then, rather than sitting in a group. You have no idea what they're doing out there, but when you see firsthand, the man that had the, he didn't have heat, so he had pots on the stove, boiling water. You know, so we go in and like, there's pots on boiling water. You know, because he hadn't mentioned that he didn't have heat, whatever, and we figured it out. So we tried to get him resources to get his furnace fixed, because we asked him, oh, what's going on with those pots? You know, oh, my heat, my furnace is this and that and that. So I said, well, we'll try to see what we can do to help you out with that. You know, and so we do try to help people out. And as far as the bed bugs, someone, you mentioned bed bugs, and, you did. And the situations that you may find yourself in, and I had to laugh at myself because we were on our way to this house, and it was like, in my travels, like kind of in the travels, not in my direct neighborhood, but I've seen this house before, and I always wondered what that house looked like. It's really interesting from the outside and whatever. And here we go, tipping in, you know, with our bags, and the man opened the door. I was like, oh my God. I said, I appreciate it. This is one time we did open our trunk, but nobody was standing around, thank God. I said, Patricia, you want me to hold your bag right there? She says, here, Deb. We found those bags in the trunk. All right. I was early, and we learned, because there's no way we're taking our stuff into that house. And the poor man, you know, the situations that people live in, you know, like I said, this was my first experience, and he was sweeping the floor for us, sweeping the dust all up in the air. It was like a layer, it looked like dust or dirt was inside the house, and he's sweeping, so that means it's all in the air. We had no mask, we had no, you know, of course we couldn't do that. And we're sitting there and surveying, or, well, where would you? And he had one stool that was wooden,
That's a good place to sit.
Yeah.
We sat. The other chair had
Yeah.
cloth in it,
Yeah.
so we just scooched over and said, oh, well, we'll sit here, you know, we're used to sitting close together. So we'll sit here, you know. Oh my gosh.
That's like explaining why when it's 5 degrees out, you're not wearing your coat. Honey, aren't you cold? No, not really.
Not class. And
I maintain heat.
And one person, one of our coordinators, she said she went to the thrift store and she bought a set of clothes just for work, like a special coat, and she only wore that to work. You know, so people think of different things. I mean, I hadn't thought about that, but she had, you know, she said, well, I only pay $1 for this, and I'll wear this when I'm going out, you know, if I have to sit down somewhere for protection. You know, just in case. But you think of things, you have to, and you see the situations that people live in, and it's so sad. Because as bad as you thought somebody lived, you'll see somebody who's living in worse
I don't
than
mean
that.
to change the subject, but on the news this morning, they had this gentleman, he was so fed up with the housing, he had bed bugs really bad. Took a cup full to City Hall, it's in another state, and threw it on a countertop. Because
Oh
he
my
said, I'm
God.
tired because he's been asking them for help.
A
So
cup
he just took a cup full
Yeah,
and threw it on the countertop down at the City Hall. This was in another city. Because I thought it was here in Baltimore. I was like, but it was somewhere else.
That poor
Well,
clerk.
that's one way to stick it to the man.
Seriously, he probably freaked out.
Oh my gosh.
He had a cup full
A
of bed
cup
bugs
full
to
of
even
bed
do
bugs.
that.
The gentleman on TV said there
That's a
had
lot.
to be at least 100 of them. Some was moved. They said at first they thought it was coffee, you know, coffee grounds. Then when they saw them starting to move, because you know when a bed bug bites,
Alright,
sucks
let's
blood,
not
they
talk about
turn a
bugs
dark
anymore.
brown. And don't ask me how I
Sounds
know.
pretty bad.
Don't ask. Because we had plenty of patients.
Oh,
He took and threw the cup of bed bugs on the countertop. I was like, I just sat there and looked at the TV like, because I thought it was here at the City Hall. When they said another state and another city, I was like, thank God. So you never know.
We had too much security. They will stop you and frisk you and ask you what you got in your hand before.
You got this one.
Even when you go in like housing, they got security like right there. They don't check you though, they just get your ID, so I can
Right,
imagine
so
that.
you could
That
have it in the
happened
bag
here.
and.
Oh my gosh.
Have you walked in
Yeah.
like with his cup of coffee?
A bag of bed bugs,
That's right. You know that was a whole lot of
a
them.
cup of
So, yeah, there's a lot of situations that you aren't prepared for that are gonna show up. So you really have to keep an open mind. You really have to be creative, what you say, what you do. And of course, like I said, sometimes you can't meet at the home, and so you have to have alternative places to meet, and we did do that a couple of times. One gentleman didn't feel that his home was comfortable enough or safe enough for us to come to him, and he asked could he do the home visit in our office. So we did. And of course, we couldn't look in his refrigerator or anything like that, but you write it up. Because he was already, you know, on the rolls. You know, one's randomized, always analyzed. So you do what the least common denominator is for a research study. And as far as we were able to give him the blood pressure machine, we were able to teach him all of that. So we weren't able to check his kitchen, but we documented all of that to keep them in the study. And then, of course, you know, if you feel safe, you feel unsafe or whatever, you get out of there and you reschedule the appointment. If it's personal safety, call 911. You know, if it's like that, and report the incident to your supervisor. So those things, you just always keep that in mind. And then, you know, you all know that. But sometimes when things happen that you weren't aware of, and it just pops up, and sometimes you're, sometimes you're just not ready for it, and you may not be the advocate, like where you could advocate for somebody else. Oh, this happens, you blah, blah, blah. But same thing could possibly happen to you and you don't catch it until later. And so you've got to be aware and be alert. And you don't want to be negative that, oh, you know, die with everything and warding off all that, but just be alert for your own safety. And if you're feeling a clue and you're feeling it, act on it, because you're getting that message for a reason. We had, I just wanted to say, because I noticed on there something about uncooperative participant, what we call participant. We had a lady who went to her home. She was extremely rude, very rude person. And you're thinking, well, why did she sign up for this study? She wasn't taking her meds, you know, wasn't doing this, not going to that appointment, whatever. When we took her blood pressure, it was extremely high. Well, that triggers the next step. We're supposed to call the nurse in the clinic and let the nurse talk to her to get her to come in. We put her on the line with the nurse. You know, her cell phone rang and she put the nurse's line down and started talking on the phone, and we could hear, because we put it on speaker. Is so-and-so? Is so-and-so? Wait a minute, I got a call. Rude, rude, rude. But we figured, because this lady was so rude, and we offered her, now it's usually, once randomized, always analyze, and you want to keep everybody in the study that you possibly can, and you try to think of some way to keep them. We offered her an out, because she does not have to stay in the study. She did not want us to come to the home. If she does not want to take her medication, she does not want to come on the visit when she should come in. You know, you got to question it and say, you know, well, we thought we could help you out, you know, and we're here. What is it that we can do? You know, blah, 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 blah. She wouldn't take the out. So we said, well, she would take the out. She's getting something from this. So we'll continue to call her. And she was there for the calls. She just said she wasn't doing anything that we asked her to do. But there was something there, and whether it was the attention she was getting, and some people will turn around later. It may not be when you want them to, or like some people get it right away and they understand this is for the help. But she knew there was something there and that somebody cared about her. So she continued to take our calls. She started to make little changes, but my other partner over there, Valerie, says, oh, it's time to call Ms. Smith. I don't want to call her. I don't want to call her. I said, give me the phone, let me call her. She might curse me out again. She said, I'm just tired of the negativeness from her. And I would call her, talk to her. You know, so you have difficult people, you're going to have them. I mean, we meet them all every day in life. And you just try to figure out, if somebody's doing something unusual, as you know, and it's against everything, there's a reason why they're doing it, and it's not usually the surface thing that's going on. And if you can tolerate it, and then if you work in teams and you can hand off to someone else, maybe someone else can deal with that person better than maybe you can. Like Valerie and I used to switch up when she would get that person, and I would call the person, you know. And I had people that she would call, you know. So you just work with the people. People need help. They're in poor health, and we know they need help. And you want to help our population and whoever we're working with. You know, I see everybody's working from all over. You want to help the people. That's why we're doing this. We want to help people. And you see what you can do. Some people get it. Some people don't. We had some success stories too. I mean, I know it's not home safety, but we talked to people. There was one gentleman who, I always like his story, who was in extreme pain. He had a severe injury years ago and kept him in severe pain. And he had this lady who was his partner, his significant other, lovely, lovely woman. She would want to answer all the questions for him.
You hate that.
She said, and I said, oh, Miss so-and-so. I said, oh, it's so lovely to talk to you each time when I call. I said, but could I say a few words, Mr. so and such. She said, oh yeah, I'll put them on the phone. Oh, no. She'd call it. And she would put them on, but she would do that all the time, so we were used to it. So when he came to taking his blood pressure, he would have like some spaces missing, because we would ask for the last 15 days or whatever days or whatever. And I'm like, what happened here? She said, oh, he was, I said, Mrs. Sosa, well, what happened? You know, she said you were in a lot of pain. She said, yeah, I was in a lot of pain. And I said, you know, can I give you a suggestion? I said, you agree that this is very helpful for you to take these blood pressures every day so you know what they're like. And then when you come to the doctor, your doctor knows what your blood pressures have been running in the last month. And he doesn't have to just take it that one day, and you agree to that, right? And he said, oh yeah, it's important. I said, well, let me introduce this to you. These are all pretty good blood pressures here, the ones that you have. I said, but what about these days that are missing? You have no idea what they are. And these are the days that you were feeling so bad, such pain. And then I spoke to her, and I said, you know, you can help him out. Anybody can help him out. On those days that he's in all that pain, you can help him out to take his blood pressure, as we taught her to. Take his blood pressure when he's on those days. And that tells the doctor the whole story. That this is when he's not in pain, but this is what his blood pressure looks like when you're in pain. Because as we know, it's probably going to be up, but the doctor needs to know how far it goes up. And that helps with his treatment. She said, that's a good idea. I'll talk to him. You know, so she talked to him. Well, the next time he came in, he had blood pressures on the pain days, and I said, right on those days, these are days he's in pain. Just put a P. In pain, in pain, in pain. And she said, Miss Gayles, we got their list. We got the list, and these are the pain days. I said, awesome, awesome. That is wonderful. I said, you know how much help that's going to be for his doctor now to help to treat him when he's in pain? And she said, I'm so glad you mentioned that. So when you have these success stories, it just warms your heart, you know, that somebody gets it and that this person can be helped a little better. So that's all I have to say, but be safe, enjoy. I know you all love what you do, and that's the main thing. If you love what you do, you're going to think of the best way to do your job. And thank you very much for inviting me.